Hi, this is Dr. Bhargava, and here is another series of interesting body imaging cases. This is our first patient, and on this scout image from their CT of the abdomen and pelvis, we find that they have a gastric lap band. This is the port to inject the saline to make it tighter or looser around the stomach, but the gastric lap band is not in a normal position. It's supposed to be right here at the or close to the GE junction, and it has slipped distally into the stomach. These are more images showing that the lap band has slipped distally, and because of that it's probably not working, and the patient will gain weight because the lap band is not working. And here on the sagittal view we see the port where saline is injected or withdrawn to make it tighter or looser around the stomach. So great example of a complication from gastric lap band. This is our next patient. They presented with abdominal pain and vomiting, and we performed a CT of the abdomen and pelvis, which shows these markedly dilated bowel loops with air fluid levels. And we see the haustra here on the coronal image, suggesting that this is colon and not small bowel. Small bowel loops are all collapsed right here, and the ileocecal valve is probably competent. That's why so far the pressure has not gone back to make these small bowel loops dilated, and the colon here is dilated because right here we see this apple core lesion, which is circumferential mural thickening involving the mid descending colon from a primary colonic adenocarcinoma. This next patient presented with abdominal pain and swelling, redness and tenderness at the region of the umbilicus, and their CT shows that there is a collection with thick rim enhancement and surrounding fat stranding consistent with abscess formation. Now, something like this could either be a result of bad hygiene, or it could be a result, or it could be iatrogenic, because umbilicus is the site of insertion of the laparoscope for laparoscopic surgeries. So an umbilical abscess. This is our next patient, and we'll start by the image on the left, which is from the barium swallow, showing the contrast column in the upper esophagus. And here we see that in the region of the epiglottis, there is a filling defect that corresponds to this irregular enhancing mass arising from the epiglottis. And we can see a good correlation between the barium swallow and the sagittal image from the CT of the head and neck. So an epiglottic cancer, we want to pay attention while doing barium swallow studies to any filling defects on the contrast column, which could be from a case like this, cancer, or a prominent cricopharyngeus muscle, or sometimes even large osteophytes that arise from the cervical spine can cause filling defects or push the contrast column anteriorly. This is our next patient. They underwent a CT of the chest, and the finding which is seen in the skin is incidental. And so we see two foci of marked skin thickening. And this is a great example of keloid. Keloids are hypertrophic scars. Some people are prone to it, and sternum is a classic site for it. So when there is injury to the skin, there is scarring, and the scar hypertrophies to look like this on CT. This is our next patient. They were diagnosed with head and neck cancer, and they underwent a FDG PET CT for whole body staging. We see the primary in the right side of the face, likely arising from the right submandibular gland, and that finding is seen right here. There is evidence of metastatic disease to level 2B lymph nodes, and there is a focus of hypermetabolism in the adrenal. And so here is the adrenal tumor that shows focal hypermetabolism. We want to see focal uptake more intense in the liver and with SUV more than 2.5 to call it concerning for metastatic disease. This patient underwent biopsy, and this was a rare solitary adrenal metastasis from a head and neck squamous cell cancer. Okay, so other incidental finding in this patient, on the whole body scan, we see excretion, which is physiologic from the kidneys into the urinary bladder, but we don't see any left renal activity. And here is an image from their CT of the abdomen and pelvis showing that is because the left kidney is atrophic. This is our next patient, and on this plain film of their abdomen and pelvis, we see that they have a double J ureteric stent, and the distal part of the stent, which is in the urinary bladder, around that we see a lot of calcifications in layers, and so a stone has formed. And so let's take a look at cross-sectional imaging. And on the CT scan shown in bone windows, we find that this is the large stone. The distal end of the catheter is buried inside the stone. Here is another image showing that there are also concretions around the proximal end of the catheter. So the catheter has been there for some time. It's probably non-functional, and a lot of concretions and stones have formed at both ends and along the length of the catheter. So it's important to recognize that on a CT scan when we are reading the study in a patient who has a ureteric stent or a percutaneous nephrostomy catheter, to identify these concretions, and these are best seen on bone windows. Here's our next patient. They presented with abdominal pain and underwent a CT of the abdomen and pelvis. On this axial image, we find that they have a horseshoe-shaped kidney, and in the right ureter, we find that there is an obstructing stone also seen right there. Proximal to it, there is dilatation or hydroureter, and there is mural thickening and surrounding fat stranding, and we see the same finding right here. So an example of UPJ stone which is obstructing the right proximal ureter in a horseshoe-shaped kidney. So remember that in horseshoe-shaped kidneys, the inferior poles are fused, and the ureters would go anterior to the kidney, going inferiorly into the pelvis. All right, so this is our next interesting patient. They presented with right upper quadrant abdominal pain. There is a remote history of cholecystectomy, and I'm showing you multiple coronal images from their CT of the abdomen and pelvis with these subtle findings of enhancement around a focal hyperdensity at several sites around the liver. And so what are these? So a comparison with their prior CT scan showed that they were stones spilled at the time of cholecystectomy. And this is their prior CT, which shows signs of acute cholecystitis. The gallbladder is distended, there is mural thickening, and there are these tiny hyperdense layering stones. And so these stones, some of them have spilled into the intraperitoneal compartment after or during cholecystectomy. And now the patient presents with these findings of developing abscesses around these stones. So a very useful comparison to a prior study, and to know that spillage of stones can happen at the time of cholecystectomy, especially laparoscopic cholecystectomy, and these spilled stones can develop abscesses. So the comparison to the prior is important because we see same dot-like hyperdensities as gallstones as we see around, as we see on this current scan, as the focus of where the abscess is starting to form. All right, so here we have a graphic showing the different segments in both right and left lungs. And so what you can do is pause this video and figure out what are these different segments, and then go to the next slide where the answers are shown. So segmental anatomy is important. Whenever there is a lesion, let's say a lung nodule which is resectable, we want to describe it in the right segment so that a segmentectomy can be performed. When there are mismatched perfusion defects on a VQ scan, we want to describe them whether they are segmental or not. And as you know, more than 2 large segmental mismatched perfusion defects qualify as high probability scan for pulmonary embolism. So in the right upper lobe, we have apical, anterior, and posterior segments. In the right middle lobe, we have lateral and medial segments. In the right lower lobe, we have superior, anterior basal, lateral basal, and posterior basal segments. In the left upper lobe, we have apico-posterior, anterior, and superior and inferior lingular segments. And then in the left lower lobe, we have superior segment, we have anterior basal, lateral basal, and posterior basal. The medial basal is behind this, so it is not seen on this view. This is our next patient. They presented with PE-like signs and symptoms, and we performed a CT of the chest PE protocol, although they did not have acute pulmonary embolism, but they have these round nodules which are multiple in both lungs, consistent with metastatic disease, and also they have this focus of consolidation involving the right upper lobe. So they have two findings here: widespread metastatic disease and also consolidation from pneumonia in the right upper lobe. Here is our next patient, and this patient was diagnosed with a pancreatic neuroendocrine tumor, and we performed a dotatate PET CT for their whole body staging. On this rotating image on the left, we find physiologic distribution of the tracer with focal intense uptake in the pituitary, which is characteristic. Then we see mild symmetric uptake in the nasal mucosa, salivary glands, spleen more intense than the liver, excretion from the kidneys into the urinary bladder. Then this large mass in the mid-abdomen, which is their locally advanced primary pancreatic neuroendocrine malignancy, and then these other foci. So this focus is definitely in the liver. We see it right here. This focus that is projecting to be in the lungs, like right here, is actually not in the lungs, and that is a misregistration artifact. And this focus right here in the shape of a vertebral body is a bone metastasis to one of the lumbar vertebral bodies. Let's take a look at some more images on this patient. And so we find that on their contrast enhanced CT, the focus right here that projects in the lung base is actually at the dome right here, seen as an enhancing focus. And because there is misregistration, which commonly happens in the region of the diaphragm, because the position of the diaphragm is different during a breath hold when the CT is acquired, and during normal breathing when a PET CT is acquired. So PET is putting it here, but the CT shows that the lesion is in the liver. So remember that there can be misregistration in the region of the diaphragm between the CT and PET images. All right, this is our next patient, and on this plain film of the abdomen, we have several findings. One, we see the descending colon with this innumerable little hyperdense outpouchings. This is diverticulosis. The individual diverticuli are hyperdense because of stools that are old and they've been there for some time. And the other important finding is these calcifications in the pancreas. So this patient also has chronic pancreatitis. These are multifocal calcifications throughout the pancreatic parenchyma in the pattern of the anatomy of the pancreas. This is our next patient, and this is a female patient, and we performed a MRI of the pelvis. On the top, there are T2 weighted images in all three projections. So we see urinary bladder, and then we have the colon with some diverticulosis, and then we see this ill-defined fluid collection, which is T2 hyperintense, and it does not show any enhancements, septations, or suspicious findings such as mural nodules. Here is a DWI image, here is the ADC image, so there is no restricted diffusion. So a finding like this, which is non-encapsulated, is ill-defined, and it's insinuating in between the surrounding pelvic structures, is a peritoneal inclusion cyst. This is our next patient. We are looking at multiple images from a ultrasound of the thyroid, and there is a large nodule in the right lobe of the thyroid. So this is where it's measured. Here we are showing the blood flow or color Doppler signal in that nodule. This is its appearance on the CT coronal image. That's the nodule with internal calcifications. And here is the other lobe of the thyroid, the left lobe, which is normal. And this was biopsy proven to be thyroid cancer. The classic finding here are microcalcifications, which are characteristic of malignancy. So this is a solid tumor, and it shows microcalcifications suggestive of a primary thyroid malignancy, turned out to be a papillary thyroid cancer on biopsy. Here's our next patient, and we are looking at multiple images from their CT of the abdomen and pelvis. The interesting finding here is that the Foley catheter is not in the urinary bladder. The balloon has been inflated in the urethra, And because of that, instead of draining the urinary bladder, it's occluding the urinary bladder. And so we see marked distension of the bladder, also bilateral hydronephrosis secondary to that. And also in this coronal image, we see the balloon right there. So it's very important to recognize when these catheters and lines are misplaced and we see them on our cross-sectional imaging. This is a finding where we would want to pick up the phone and call the provider, hey, this needs to be deflated and removed as soon as possible. This is our next patient, and we are looking at ultrasound images of the liver, which shows a 1.7 centimeters hyperechoic round focus in the left lobe of the liver. And we know that hyperechoic lesions commonly are hemangiomas, and these are follow-up images on the same patient where we're looking at a T2 weighted image. We see T2 hyperintensity, and on contrast enhanced images, these are T1 fat saturated post-contrast images, pre-con arterial phase, and the delayed phase. We find that there is progressive centripetal enhancement in this lesion consistent with the hemangioma. This is our next patient, a young female who presented with right-sided pelvic pain, and we performed a pelvic ultrasound. These are transvaginal images showing the right ovary, and the right ovary has this large cystic focus with low-level internal echoes. This measures about 104 ml in volume, and there is no color Doppler signal inside it. There is some color Doppler signal in the wall, and so these findings are consistent with a hemorrhagic cyst. These findings are a common cause of abdominal pain in young females of childbearing age group, and when we see them, we want to ask for a follow-up scan in 6 to 8 weeks to make sure that something like this has resolved. Hemorrhagic cysts generally resolve, and so hemorrhage happens when a developing follicle breaks through the capsule of the ovary during ovulation. And so at that time, when there is ovulation and the ovum is released, and this follicle breaks open into the intraperitoneal compartment to release the ovum, there is some hemorrhage inside. And so hemorrhagic cysts happen, and over a period of time, in the next couple of cycles, they resolve. Here is, so this is from December 2022, and here is a follow-up, which is from July 2023. We see now that the right ovarian volume is normal. Here is the ovary showing normal developing follicles inside. And so just looking at the image, you may not, or you may feel like the size here is similar to the size that I was shown previously, but always look at the annotations of the technologists and the footprint of the probe. So here, this is like a transvaginal probe. This is a transabdominal probe. And the volume has gone down from about 104 cc's to 10 cc's now. And the hemorrhagic cyst that we saw previously has resolved. This is our next patient, and this was an incidental finding on their CT of the abdomen and pelvis, where on this axial image, more inferiorly at the level of the femoral vein, we see a filling defect inside. And so this is what DVT looks like on a CT scan. On this coronal image, we find the DVT right there. Proximally, we find that there is a stent and there is in-stent thrombosis. And so this is also shown right here. The stent is extending from the left external iliac vein to the IVC. So this patient was first diagnosed with May-Turner syndrome, and they were treated with a stent, and now there is an in-stent thrombosis leading to this appearance on the CT. That's it for this series. Thank you for watching.